Welcome, everyone. We're going to start today's broadcast with a video showing the impact that pharmacists are having on COVID vaccination. So please join us before we get started to view this very short video.
People in the community wanted to get vaccinated, but they didn't trust certain places at the beginning of when we started with the vaccines. We have a food distribution, and every Tuesday we distribute to 600 plus families, and they started asking us, are you gonna have the vaccine? Then we got about 100 people that were ready to vaccinate it, and they wanted to be vaccinated. After we saw the need, we started registering people and waiting to see how many, and here we are. We have been able to knock at the doors and convince, especially the Latino community, to come and get the vaccine. And many people say, we do it if we do it in your church, because we trust the church. The church has been with us, they said, for the whole pandemic. They said, you're the pastor, if you say to me that it is safe, I will believe you. It feels really great. It feels like this is a big effort of the church volunteer people. They have gone and explained to people why we should get the vaccine. And this is the turnout.
Well, welcome, everyone. My name is Sandra Leal, and I am Executive Vice President at Tabula Rasa Healthcare, and I'm also the President of the American Pharmacists Association. And we wanted to welcome you to today's open forum series for pharmacy building vaccine trust with patients, addressing the COVID-19 crisis. Today, we'll be discussing predominant and emerging drivers of mistrust in COVID-19 vaccine and how to approach conversations when building trust with priority populations, including parents and young adults. This webinar is funded in part by a collaborative agreement with the CDC, and we're very excited to have two incredible featured speakers that will be talking about some of the questions that you're probably seeing in practice every day. Our first speaker is Amina Abubakar, and she is the owner of RX Clinic Pharmacy in Charlotte, North Carolina, and founder of the Advent Institute, which is offering training to pharmacies across the country on the practical applications of clinical pharmacy services through sustainable physician collaborations. She is an internationally recognized award-winning clinical pharmacist. She is certified HIV specialist and the preceptor to UNC Chapel Hill residents and students from several schools of pharmacy. She collaborates with medical providers to expand pharmacist-led clinical services in her community, and her sites care for a community of refugees, immigrants, patients with HIV, and a large senior population. I am a big fan of Amina, and I know that you've probably heard her name many times. Our second speaker today is Coleman Cutchins, and he is a clinical pharmacist at the State of Alaska Department of Health and Social Services. His experience includes population health, academia, inpatient acute care, infectious disease, antimicrobial stewardship, clinical ambulatory care, and quality improvement. During the COVID-19 pandemic, he has served on the department's medical leadership team and has been instrumental in medication education and implementation, clinical guidance, patient triage, travelers protection, outbreak responses, healthcare policy, and is the Alaska SARS-CoV-2 testing lead. He has partnered to support school, industry, critical infrastructure, communities, and government. We are so lucky to have you, Coleman and Amina, join us today. We also have our subject matter experts for Q&A, and they include Mitch Rothholtz, and he's the Chief of Government and State Affiliates for the American Pharmacists Association. He is also the APhA Executive Director for the APhA Foundation and brings a long history at APhA as our vaccine expert. We also have with us today Dan Slott, who's the Senior Vice President of Education and Business Development at APhA, and he brings 10 years of experience at NIH as an oncology infectious disease specialist. And we also have with us today Elisa Bernstein. She's the Senior Vice President for Pharmacy Practice and Government Affairs at APhA, and she brings 30 years of experience at the FDA. So we will have CE today, and let me just point out the disclosures. I'll leave that for a second for you to read. And with our CE presentation, we have these learning objectives. The first one is discuss predominant and emerging drivers of mistrust in COVID-19 vaccines. The second one is describe challenges and solutions for building trust with patients to increase the COVID-19 vaccines. And the third is discuss how to approach conversations when building trust with priority populations, including patients and young adults. Let's go through the next few slides for the pre-assessment questions for today's CE. The first question and the first poll is, which of the following is not a common misconception and emerging driver of mistrust in the COVID-19 vaccine? Great, thank you. Let's go to the second question. Which of the following is a solution for building trust with patients? And our third question, if a patient has a history of myocarditis or pericarditis prior to COVID-19 vaccination, CDC currently recommends the patient do what? All right, so here's a little bit of a review about today's webinar. We've just gone through introductions, and we will go ahead and start an interview with Dr. Amina Abubakar and Dr. Coleman Cutchins. And that'll go for about 25 minutes. At about a minute and 30, we will go ahead and review any questions or comments that you might have that you can place in the toolbar. And then at the end, at about a minute, an hour and 50 minutes, we will go ahead and go with an APhA update on breaking news, breaking information that we have. So please feel free to add information. We also have the handout at the GoToWebinar control panel for you to download as you're reviewing this webinar. So let me introduce the two speakers. Welcome, Amina, and welcome, Coleman. Thank you so much for being here. It's wonderful to have both of you share so much incredible information that we're going to talk about today. So let's start with you, Amina, and can you tell me a little bit about your practice and briefly discuss how you are building on the COVID-19 trust in your pharmacy practice and within your community?
Sure. So we're located in Charlotte area, and our pharmacy is home to like the refugee population. We have HIV patients. We have a lot of minority groups that we serve because a lot of our staff, we have like Vietnamese, Spanish, and so we have a lot of their families, friends, and communities utilizing our pharmacy. So one of them is to actually utilize these individuals to help us penetrate their communities with like language barrier, different faiths also. So that's what we've done. We've done more community partnerships to build trust.
That's great. Well, it sounds like you have an incredible practice and you're impacting so many people. So I'm sure they're very happy to have you there, be an access provider. Coleman, thank you for joining us today. So can you tell us a little bit about your practice and what you're seeing up in Alaska?
Sure. So I'm a clinical pharmacist for the state of Alaska Department of Health. So my practice is really population health over the entire state. Just a reminder, Alaska is pretty much as big as the entire lower 48. We have a huge geographic spread. We're also the most culturally diverse state in the country. And we also have only about 17% of our communities are attached by road systems. So I like to joke that we're a huge network of islands. They're just islands that have land between. So a lot of variety across it. What we're really doing is just outreach, meeting people where they're at, understanding that through that diversity, different messaging works for different populations, and also working a lot to empower local communities and local leaders. to develop vaccine trust and good resources that's specific to the end user.
And so, Coleman, just as a follow-up question, what do you think is leading to the mistrust that we're seeing with the COVID-19 vaccine? And I know there's so much coming out, but what do you think is contributing to that?
You know, I could probably talk for an entire hour about this. You know, overall, I really think it's not just the vaccine, it's been the entire pandemic. You know, we have, in today's day and age, we have so much information, and I think people just have a hard time realizing what's reliable information and what's not reliable information. And I think that's been, you know, really the theme through the whole pandemic. So us as healthcare providers, and I think specifically pharmacists, were uniquely positioned to really be a strong resource to educate our friends, family, and our patients.
Yeah, absolutely. I definitely agree with that. I know I'm getting a ton of questions from my own family every day about what's true and not. And I'm in the border area, so I'm hearing a lot of the things coming up from Mexico that my family is asking me about. So Amina, what are some of the predominant myths you are hearing from your patients in your community?
So interesting for us, because of the diverse patient populations, their misinformation is coming from so many WhatsApp messages from family overseas. And we didn't realize that we're doing so much work in the US, but their messaging is being filtered. And some of it has a political twist because it started around the whole election, and then why the vaccine has now been brought to the US. So some family members are discouraging them because they don't have vaccines in those countries. So it's kind of like asking them, why don't we have the vaccines, and not understanding that they don't have access. We've been privileged to have access, and it has nothing to do with America is being set up post-political issues. So I never thought to think like that. You know, we're all thinking about what's happening here with anti-vax, but so information is coming from there. But most recently, I'm getting from our younger technicians who are on social media and TikTok, and they were telling me about that there's a chip and the magnet that it sticks. And so we had them actually do it. What I realize is when people hear these things, they don't try it. They just forward these messages, right? And so when you're forwarding these messages and people trust you, they forward to more people. So we had them do the experiment, and it actually failed. So we told them the importance of verifying information, linked them to the CDC, and we found it online that there was a reference. So this is a non-myth right now. So we are trying to tackle this.
Oh, I know that. I've heard the magnet one also, and I'm very much into social media and see these posts. But you're right, Amina. The WhatsApp, especially in my my mom's community, the Hispanic community, they've been sending all these very interesting videos and a lot of information that's just incredible to me. So you know, I'm just talking and trying to answer questions and using the own experience of having received the vaccine to hopefully convince them that it's okay. And that it's been, you know, it's been safe, at least for those that have taken it here. Coleman, you know, what do you think is continuing to add to that mistrust? And do you think that approval for the Pfizer and Moderna vaccine, the approval from the FDA, do you think that will impact the trust issue or not?
You know, I think it will have an effect. I've really been doing, since really even before the vaccine hit the market, a lot of presentations on the FDA process. You know, I think if you see a lot of the misinformation is centered around people not understanding the FDA process. And I think really this graphic here that you put up is a very good visual. You know, I always reinforce, you know, we have the most rigorous, safest drug approval process in the world. It's based on the two pillars that drugs are safe and that they're effective, and that the emergency use process still went through all the steps. You know, we're hearing so much information about, you know, this is an experimental drug and it's, you know, it violates the Nuremberg Code. And I mean, just kind of preposterous things. But, you know, this graphic really shows that a lot of things were done in parallel, and it doesn't have to take that long, you know. And I also always want to let people know that it did go through, you know, preclinical, phase 1, phase 2, phase 3. It was reviewed by the FDA. It was reviewed by APhA. You know, it went through all of the same processes. They were just done parallel and expedited. And the big thing that really sped this up was that manufacturing was done prior to development, prior to approval. And I also remind people that, you know, 3 vaccines received emergency use authorization, but 2 didn't. So, you know, it wasn't like we just gave a green card to everyone that we gave funding to. So I think there's just so much confusion over that, but I also remind people that it's a very complex process, and you can't really read a couple sentences and understand it.
Yeah, that's a great point about pointing out that not all vaccines received approval. I think sometimes we just focus on the ones that did and not talk about how the process actually worked, and how in some cases we did not approve vaccines because the process was working. But I love this. I've used this graphic before to show that we didn't skip any steps, and that's really important for people to really understand that, because I think that's where I think that's one of the common questions I've received. How, you know, why was it done so quickly when it's taken so long historically for others? But this is very helpful. So, and this will go to you, Amina. What are some of the challenges you're facing, and what do you think? What have you learned works best to increase the trust with the patients and the community that you're working with?
My toughest population was healthcare workers in the assisted living or the medical assistants, because we need them to encourage the patients. So if they didn't have a buy-in, so I felt like our strategy was to do more education, because we left that population thinking they're going to jump on board, they understand, they're in healthcare, but they were one of the biggest barriers for us. So we got our medical providers and pharmacists and did training and went through the resources that I've gotten from people like Coleman, you know, and put them together from my team that we meet with the CDC opportunity. So I was able to use these resources from these healthcare workers. There was a nursing home that their vaccine rate was really, really low, and the provider there was concerned, you know, and so that education, but their biggest question was fertility for them, you know. So I'm finding the young healthcare professionals are worried about the infertility. So giving them studies and giving them that support and telling them the statistics of infertility, regardless of the vaccine, you know, these are the chances. You know, people think it's really easy to get pregnant, but actually it's not. So let's put the vaccine aside and worry about safety.
No, that definitely goes a long way, and probably just even your relationship with them historically, they trust you as a community member too. So, those are great tips, and I've heard that infertility question come up quite a bit also. Very, very interesting. How about you, Coleman? Anything that you learned best to increase trust within your community?
You know, I think speaking about the FDA process, but then also just now I'm doing a lot more talking about just the volumes of people. You know, I mean, we're at approaching 400 million doses of these vaccines here in the US. You know, if there was a big, large, glaring safety concern, we would have found it. You know, and even if you look at, you know, the clotting risk with Johnson & Johnson, and we'll talk a little bit more about, you know, myocarditis, pericarditis that we found with the mRNA vaccines, you know, we've been totally transparent, and, you know, they've been evaluated and we followed the steps and they've worked. You know, these you know, extremely rare side effects always come up when drugs make it to market. You know, I always remind people too about, you know, the labeling change for ibuprofen that we saw in 2018 to add the risk, or 2016 to add the risk of severe GI bleed or myocardial infarction. So it shows us the system works, and it shows us that we're monitoring and looking for concerns.
And also, Sandra, another thing that I learned is utilizing known leaders in those communities that look, speak, and pray like those individuals has also helped us. So I have done seminars in the mosques, like in the Arabic halal stores. And when I went, they actually said, "Welcome, sister. I'm glad you came and talked to us. Several people have, but I trust you." So that goes a long way to try and educate other people that look like them and they can relate and trust. And even translators in those communities have been very instrumental.
Now that I agree with that. I think that if you can talk to them in their language, they know you culturally, and everything about that makes a big difference. I was participating in one of the vaccine trials, so I could just, you know, be one of the first people to come out and say, here's what I did, I took it, I talked to my family members in Spanish, and use myself as a I don't want to say guinea pig, because I I really believe that it was going to contribute to the science on that. And that I think that's been a trust factor that's been very important. So I absolutely agree that that helps a lot. Now, are you taking a different approach with parents and children? Are you seeing different types of mistrust issues or concern issues as opposed to just like the adults? But anything with parents or 12-year-olds or that you're seeing, any specifics there?
You know, I've seen parents confused making decisions for their children, and they feel responsible. So I've been talking to parents saying that I'm an adult and I can make my decision, but if something happens to my child, I don't want to be the one. And that was a tough one because they want the children to make choices, but they don't have the knowledge or aptitude, you know, to understand. So that's something we're working through right now, the choice for
Yeah.
a child.
Oh,
And
that's
with
good.
children,
That's a good point.
with children too,
Go
I
ahead,
think the other thing that we're really facing a lot is that people believe that they're not affected. You know, people believe that, you know, kids don't get really sick, that kids don't get infected. But I've been speaking a lot recently. I think we're going to learn a lot more about the long-term complications of the virus, you know, and that even in asymptomatic infections, you know, I think there's a lot more things being published about long-term complications.
Yeah, now the variants have been definitely taking the headlines in the last few weeks. So let's talk about the variants a little bit. And what are you seeing about the emergent variants? Is that impacting the trust level in individuals in getting the COVID-19 vaccine? Have you seen any pickup in the vaccine or more concern? Anything that you've seen from that?
Yeah, so I think it's gone both ways. You know, the good news that I'm continuing to message now is that the vaccines work. You know, I mean, you look at national data. I mean, here in Alaska, 98% of our hospitalizations and over 99% of our deaths are in unvaccinated. National data is very similar. You know, 98, 99% of hospitalizations and deaths due to wild type and variants are all in unvaccinated. You know, we're getting more and more data saying that, you know, the vaccines work great once you've completed the full series. We're doing a big education push right now for people that didn't get their second dose of an mRNA to get their second dose, because the data coming out of the UK and Israel are showing that much higher effectiveness once you're 2 weeks past that second dose. There was another, I put this slide out, and there was another big misinformation about a study out of Israel where, and I've said this through the whole pandemic, you know, denominators matter. It's not just numbers, you know, because if you look at, there were some things in the news showing that they were having equal cases of, you know, new Delta variant in vaccinated versus unvaccinated. But what it was is they were looking at a very highly vaccinated population. So if you look at kind of, you know, the graphic here on the right, you know, if you have 83% of the population vaccinated, you may have 2 cases in vaccinated people and 2 cases in unvaccinated. But what that really means is 2% of your vaccinated people got infected and about, you know, 40% of your unvaccinated people got infected. You know, we're also seeing that same kind of not really including denominators. You know, we hear things about, well, this community has no restrictions and they've had 20 cases, and this community has masking and guidance restrictions and they had 20 cases. But, you know, the one with no restrictions has 5,000 people and the one with restrictions has 270,000 people. So, you know, I just think really with a lot of this, it's important to educate people that, you know, denominators matter in the percentages, and the overall message is that our vaccines are working very well against our known variants.
That's a great point, and the denominators absolutely matter. I've heard reports where we focus on the one person instead of the millions of people that have actually had have been preventing the infection. And any implications for unvaccinated adolescents and young children? And I know you already mentioned some of the long COVID, but anything that you've had questions about or that you've seen, or, you know, things that you're using to address concerns there?
You know, I think the data, and if you look at the data hubs, you know, our cases now are moving younger. You know, if you look at over the last month, you know, our cases are moving to you know, our hospitalizations, I should say, our cases have always really been driven by the 20 to 29-year-olds, followed closely by the 30 to 39-year-olds. But now our hospitalizations are moving younger. You know, our hospitalizations were more in the 60 plus, 50 plus. Now it's actually, we're having a lot of hospitalizations in the 20 to 40 age group. Some of that's driven by Delta, but it's also driven by that's our highly unvaccinated population. And as we get the older people who are at higher risk for complications vaccinated, we're seeing less hospitalizations with them. And I think that's really good evidence that the vaccines are working. We're not seeing, even using, talking about skilled nursing facilities, we're seeing outbreaks in skilled nursing facilities and no one gets sent to the hospital, or one person, versus a year ago, we had an outbreak in a skilled nursing facility and a third or half of them went to the hospital. So it's really showing us that these vaccines are working, that they're highly safe and effective.
How about you? I mean, any concerns that you're seeing from parents, or any statistics within your community for younger children?
No, we're seeing more uptake. I think seeing that, what he said, people who've been vaccinated, even if they're positive, they're less likely to be sick, is starting to resonate. And I think some more local football sports team, they still test them, and there were folks that were positive, but they were not sick. So I think that's showing a better example to be vaccinated when you're younger also. So we're getting more requests to get the kids. But when it comes to the variants, we're also getting people that are fatigued, saying, is there going to be a third dose now? And they're kind of having the worry that why get vaccinated if a new variant is going to come?
Yeah, we talk about that with the flu vaccine every year too. But
to remind them of the vaccine, and focusing always on the positive to show people, because it's so easy to focus on the negative, the few people that get sick, the few people that this happens to. But when we focus on the how many millions have gotten it, look at the hospitalizations rate going down, it builds more confidence.
Well, let's talk a little bit.
Another thing that I will mention, because I've been saying this a lot, I always remind people that a vaccine was in the playbook before this pandemic even started. Viruses are tough to treat. Most of them, how many times have we told patients it's just a virus, there's no treatment, you don't need antibiotics. So just encouraging people, this is the way out of the pandemic, and this was our way out of the pandemic 3 years ago before the pandemic started. If we opened the playbook, it said, figure out how the virus is spread, do everything you can do to stop that, start developing a safe and effective vaccine, and as soon as you get that, vaccinate as many people as possible, pandemic over. And I think reminding people of that it's always been our strategy and our way out is also a good encouragement to getting our kids back to their life as normal.
So let's talk a little bit about the myocarditis risk versus benefit. There was some information related to the younger populations that we saw. And what are you seeing as it relates to this concern? How do you address this with parents that are vaccinating their kids? And is this leading to any trust issues or any concerns that you're seeing? How do you address that specifically? So start with you, Coleman.
Yeah, so the first thing is I really point this out is to the system works. We did find this, extremely rare association. It's a little bit less than 1 in 100,000. The other thing is really people hear myocarditis, inflammation of the heart, pericarditis, inflammation of surrounding tissue, is scary, terrifying. But when you listen to the ACIP meeting, most of these cases are mild. They're actually encouraging providers to not overtreat them. We think about symptoms, chest pain, palpitation, shortness of breath, fatigue. Also, you can have some peripheral edema. But really, I think this chart really shows that most of these cases are mild, so even and especially in males. So when we look at males have the increased risk of myocarditis or pericarditis, males also have worse outcomes when it comes to COVID. So when we specifically look at the data that CDC and ACIP put together, the big thing I really want people to focus on is hospital admissions prevented is higher in females, but ICU admission prevented is higher in males. So this includes the cases of myocarditis. So even when we think about cases of myocarditis that possibly could have been associated with the vaccine, we're still seeing a reduction in ICU admissions, and we're still seeing a reduction in death. So really stressing the fact that most of the cases are self-limiting and mild. Patients don't need to be admitted to the hospital. A lot of them don't even need medical care. The other thing I really want to stress, and we don't have great data on this, but myocarditis and pericarditis are most often associated with viral infections. And there have been some studies that show up to 20%, myocarditis with COVID infections. There was that big study done in collegiate football players, And they were obviously they were just echoing people at random, but they were finding incidentally pretty high rates of myocarditis, much higher than we're seeing with these vaccines. So overall, it's yes, acknowledging it. This shows that the system works. We found it. Cases are mild, and this is still an extremely rare side effect.
How about you, Amina? Have you seen this question come up, and are you talking to parents about risk versus benefit yet, or is it still a little too early?
The only case that I've been involved in discussion was actually getting it while the person had COVID. So they were younger, they were in their 20s. So that's what we had to deal with. And now they don't want to get vaccinated because they think that it would happen again. So that's where we are doing the education. But now you've healed, symptoms are resolved. It's actually important because it happened before that you need to be vaccinated. Because if you get infected again, this will happen. So yeah, it was a young case, and that's all. But our community has not gone up to date with myocarditis yet.
Okay. And Coleman, do you know, like, should individuals with a history of myocarditis or pericarditis receive the vaccination?
So CDC actually put out really good guidance. I think there's a slide on that. So yes, as soon as you have resolved, you should receive one of the vaccines. They also put in the considerations there if you got pericarditis or myocarditis after your first dose. They're still recommending, under the consultant of your primary care provider, that they're still recommending you go ahead and get the second dose. Pretty clear, and you have the link there on the slide to that.
Perfect. Yeah, and I just want to remind people we have the handout with these graphics on there for your reference to the information. So thank you, Coleman, for sharing that. And we'll talk about one more topic before we jump into the audience questions, because I'm starting to see them come in here. But how do you address the concern about fertility in this patient population? Because that is, again, something that keeps coming up so much. So how do we address that to alleviate the concerns for people out there?
I think sharing the data that has been compiled, for example, this is a great reference. And I know APhA also had a whole section with other experts discussing that. It's really giving the real information. People have to see numbers. For the longest time, we've never shared numbers and statistics with patients. But this particular case, for people to see the live births that have happened since then, for patients that have been vaccinated and not complications, is the only way, because this is the toughest group and data is the only thing that is going to help.
Great, thank you. And Coleman, how about you? Any pointers on this particular issue on fertility?
I've really just been stressing the fact that the American College of Gynecology and Obstetrics highly recommend the vaccine. All of the medical professional organizations that deal with women and children's health are highly recommending vaccination. So, and I think that really speaks to, the confidence that these experts have in it.
And thank you, Amina, for pointing out, we did have a webinar earlier this year, and this is the link on that, Reproductive Health, the Impact of COVID-19 Disease and Vaccination, where we talked about women's health issues and address fertility. And we had a physician there. We had Veronica Vernon, a pharmacist who works in women's health, come in and address some incredible, questions that keep coming up around this issue. So please go back and link to this video. It's very helpful with some great talking point, because I think this is the one that still keeps coming up quite a bit. So thank you so much. So what we'll do now is we're going to go into the moderated discussion. So just a little bit of information. If you have any questions, please go ahead and include them in the questions box here in your go-to webinar meeting control panel, comments, questions, and feedbacks. And I already see a few coming up. So let me go ahead and get started reading those for you, Amina and Coleman, and if you can answer those, that would be great. So the first question comes to us, and it's the question is, one of the communities which have been vaccinating in MA, parents have allowed their children to get the vaccine, but the parents are themselves not getting the vaccine. How do I address that? And that's from Cynthia Coletta, who's asked that question. Any tips on that, where they are getting their kids vaccinated, but they themselves are not?
So I can start with this, and we have a pretty Alaska-specific messaging that we're using is, this is the way parents protect their children. You know, we have muskox up here, and elephants do the same thing. So, you know, when there's a threat around, the adult muskox actually surround the children and they point out. You know, elephants do the same thing. This is the way, you know, parents getting vaccinated is your way to protect your children. You know, we know every person who's unvaccinated has a higher risk of getting infected and spreading the disease. You know, another thing I think it's really important to remember is every person, you know, viruses aren't living. We say live viruses, but they're not living. They need a host. They need us to reproduce. They need us to replicate, you know, and every new infection is a new chance for a new variant. So, you know, the less people that we have susceptible, the less virus we're going to have circulating in our community and the less new variants we're having developing. And it truly is, you know, their way to help protect their children.
Yeah, that's a great point. Definitely. I think they're trying to do the right thing, but it would even offer more protection if they were also vaccinated. Amina, any comments on that question?
I will say the same thing, doubling up on protection for the whole family rather than half of the family.
Yeah, that's
an easy.
So let's go.
I think if you're letting the kid getting vaccinated, I think a little bit more education, and because that's a better trust than what I'm dealing with, where the parents don't want the risk for the patient, for the kids.
Yeah, that's an interesting one. I thought the question was interesting that they would let the children, but not themselves. So very interesting. We're hearing everything out there in the field for sure. This is a question from Ashley Copes, and she's asking, should a patient with diabetes who receives a Janssen vaccine in March get an mRNA vaccine? And if so, should that high-risk patient get 1 or 2 doses of the mRNA vaccine? So any thoughts about that question?
So the CDC is very clear that we shouldn't, at this point, we don't have any evidence or any recommendations to double up on vaccines. You know, all of the effectiveness data, you know, we saw 8 to 9 month data for the mRNAs, you know, the lasting immunity is strong. That being said, I think, and we're getting so many questions about boosters right now. Overall, what I'm telling people is all the vaccines work great. They're all very safe. They're all very effective. We don't have any reason why someone should get another dose. We don't have any reason to believe that anyone will need boosters. I think there will be a subset of the population at some point. You know, there was a study published last week looking at solid organ transplant recipients who got a 3rd dose in a trial. You know, we're not recommending that yet, but at this point, there's no, I would tell them, you know, there's no evidence, there's no guidance to need another vaccine after J&J.
Oh, okay, perfect. So here's a question from Federico Jones. How do we convince those who have had COVID-19 that they still need to be vaccinated? Any discussions around that? Amina, have you had any patients who've had COVID that have asked whether or not they're protected enough, or have you convinced to actually get the vaccine?
Yeah, so for those particular patients, what we've talked about is now they understand how vaccines work. So they have this temporary immunity from having COVID, but having the vaccine now, we can get them, because no one knows how long that is lasting. Plus, we've had people test with antibodies to see most frequently if they wanted to be sure. But with those patients, I feel like we've had 50-50. Some are like, yes, I don't want to go through that again, because what we told them is, now you know if you get a vaccine, you're going to build your immunity faster. So your body had to figure it out, and you went through all these symptoms. But imagine if you can get a dose so you can prevent it further. So if they've gone through the COVID complications, then they're ready. But some, if they had really bad symptoms, they are worried that it will do the same. So it's a matter,
I'm sure,
and just continuing the dialogue with them. So don't give up on them. Keep talking. We have a few that we check in now and then. Are you ready now? You know, the country's opening up, and there are more people that are getting vaccinated. We have good data. Can we get you to come in? They want to know the time frame. And I think we don't have a particular time frame for them, and that's where they're waiting.
yeah, that's a good point. I appreciate your comment about keep asking, right? Just because it's a no today doesn't mean it's a no tomorrow. And I have talked to people who've had COVID-19 and they're like, I never want to have that again. I absolutely don't. But I could see how there's still question about whether they need that vaccine or not.
Yeah, the way I'm really approaching this is just first of all, letting them understand that it's highly variable how much immunity you get from natural infection. You know, your body may develop immunity to something inside the virus that you won't see. Your body may develop, you know, something on the surface that, you know, you don't attach to. With the vaccine, you get a very specific, very calculated immune response that's specific to the part of the virus your body needs to identify. You know, I kind of use an analogy where I say, you know, if I want to find a criminal and I hand you a picture of their face, like that's what you need to see to identify them. Is that better than if you see them in person, but when you see them in person, they're 100 yards away and you see the back of their head? Like, no. So like with natural infection, there's just a huge variability in how much immunity you get. You know, some studies have shown people have almost no immunity. Some studies have shown people have fairly robust immunity. And it's really hard to know. The other thing I think that's really difficult for that is antibodies are only a small portion. You know, it's more B cell mediated. Also, the performance of the antibody tests are quite variable, and some of them are quite poor. You know, some of the best antibody tests are quite good, the ones you send to commercial labs. Some of the over-the-counter ones are like 50-50. You know, they have about the same statistical performance as a coin toss. So just understanding that the performance of the antibody tests aren't great. You know, that all of the guidance says the antibody test should not be used to make clinical decisions. And also with natural infection, you get a wide variety of how much immunity you get. For the vaccine, we know you get very robust, very complete immunity to the actual part of the virus that your body needs to identify.
Yeah, good points. That's good information about the test there, because there has been variability reported. So appreciate that. Here's a question that's a little bit specific. Not sure if you have information about it, but Warren Winston asks, he's making a comment about the Marshall Project, which states that only 49% of inmates have gotten the first vaccine dose and far less the second. And then the question is this number correct in the federal prison systems? And I'm not sure if either of you have any data or information on that, but just wanted to put it out there. Maybe we can get back to him with information. I
will say I have no idea for the federal prison system, but in the Alaska state prison system, we've had fairly high vaccine uptake rates. You know, and the big incentive, and I think we can mention this with family and kids, is not needing to quarantine when you're a known close contact. You know, I think for for inmates, that's been a huge incentive that, you know, when they're a known close contact, they don't have to quarantine if they remain asymptomatic. And we've had very high vaccine uptake in our state correctional systems.
Great, thank you. Here's a question for clarification on the fertility chart from Melissa Weingartner. She's asking, is the published incidence column for general population? And that's the question on the fertility chart. Published incidence column for general, is that for the general population? I don't know if we can pull that that chart up again. We can. All right. So is the published incidence, is that for the general population? And I don't know if either of you know that response or not.
I believe it is. This is from the New England Journal article. Yeah, I believe the published incidence is like what we're expected in general population. And then the column on the right is comparing that to what we've seen from the VSafe data.
Okay, thank you so much. All right, let's see here. Let's go to the next question. I'm glad there's a ton of questions. This is great. This is from Alexis Page. I've had patients share with me that their other healthcare providers do not want them to receive the vaccine. How do you address patients when they state their providers are uncomfortable with the vaccine? And I know, Amina, you had a specific example like this. Do you want to share your experience?
Yeah, so we have a provider that shares publicly that he is not recommending vaccine for his patients. So for a pharmacist, you're always in this predicament because that's their primary care provider, you're the pharmacist. We've given the patient the information, the risks, the benefits, and let them make their final decisions. And also encourage them to get a second opinion, like this is what's happening. But I've also approached the provider to hear their why behind it, to see if they have data that I don't have. So I always approach them with curiosity. Where is this coming from? And that particular provider had a closed provider that lost their life after a second dose. So we talked about it, but he's still hesitant and he wants his patients, he doesn't think it's a risk. He said, unless they're high risk, then I may encourage them, but I think young people shouldn't. So yeah, give the information. It's your duty as a pharmacist to give your patients all the information, ask them questions. What do get their myths, work with the patient, give them a choice, but highly encourage with all the data that we have.
Yeah, I mean, that's a tough place to be for sure. It's difficult, but I appreciate you talking to the provider to find out what their why is and hopefully clarifying directly from the source. I always figure if you could counter detail the provider, you're impacting all of their panel at the same time and not just one individual person at a time. So I like that technique. Coleman, have you seen this in Alaska? Any concerns, any questions related to providers not recommending the vaccine?
I think Amina said it really well. It really comes down to education. I mean, we have had some of it. I will say it's been kind of more of the non-traditional providers, acupuncture, chiropractors, naturopaths. Some of them are very pro-vaccine. Some are very anti-vaccine. Some of them were very anti-vaccine prior to all this. So I think really approaching it, not trying to get into an argument, but definitely presenting what the data says and giving your patients what the information and data says and what the guidelines recommend.
Thank you. Thank you both for that. So here's a question from Hina Patel. If a patient only receives one dose of the AstraZeneca vaccine outside of the US prior to coming to the US, what would you recommend?
So I recommend that, this is addressed in the CDC frequently asked questions for clinicians. So if they have completed the series of a WHO approved vaccine, they would be considered fully vaccinated. One dose of AstraZeneca isn't completed the series, so then you would start with any of the vaccines available here in the US and complete the series. So either one dose of Johnson & Johnson or 2 doses of Pfizer Moderna.
Perfect. Thank you so much. So follow the vaccines here if they have not completed this series. Okay. Thank you. All right. We have a question from Judy McDaniels. Why is the immunity with wild type chickenpox is lifelong, but immunity with wild type COVID is not lifelong?
So I've approached a lot of these chickenpox questions. I've gotten a lot of these. So I first of all remind everyone that, not all infections are the same. Not all viruses are the same. When you look at chickenpox, is basically, a herpes family virus. They don't mutate a whole lot. The other thing I remind people of, and I use this as a pretty good example, for vaccine versus natural infection. So, I'm older than the chickenpox vaccine, so I got chickenpox. I have a pretty significant risk of developing shingles later in life, when that virus decides to remanifest at some point. If you look at someone who's 10 years younger than me and got the chickenpox vaccine, they're probably not going to get shingles because that vaccine is preventing them from getting that asymptomatic infection. So I think the chickenpox is a good example of where vaccine works better than natural infection, because people who get chickenpox have that higher risk of, and that virus stays in your body forever, has a higher risk of developing shingles later in life than somebody who gets the vaccine. And I also just remind people, SARS-CoV-2 is a RNA respiratory virus. We know that they mutate a lot, and we know that we can catch these over and over again when we get natural infection.
Great. Well, that's a great question there. I hadn't heard one before on chickenpox, but glad you had and glad you were able to address it. And then just one final question, because we do have to get to the post questions here. But when do you all think that the Moderna vaccine will get approved for the 12 to 17-year-old population? Any thoughts on that, or have you heard anything about that?
I have some good news on children. I don't know if everyone noticed yesterday that Pfizer met enrollment for 5 to 11-year-olds. So they've met enrollment. They're no longer enrolling in that trial. I would have guessed that Moderna would have had 12 and ups already. We're getting a lot of these questions, but I always take them that Pfizer's approved, readily available, and give it. The best vaccine is the one you can get right now. I'm surprised it hasn't been already, personally, but I don't know when it'll come.
Sandra, this is Mitch. I gave an update in a discussion yesterday. It was said that probably middle of July to expect the authorization for the Moderna for 12 to 15.
Perfect. All right. So any day now. So we'll keep our eyes and ears open and share that with the membership here. Well, thank you so much, Amina, and thank you so much, Coleman, for everything that you've been doing during this COVID-19 pandemic, but everything that you've been doing previous to this and that you will continue to do post this. You are exceptional examples of the amazing work that pharmacists are doing, and I appreciate your time today to share with us. So thank you very much. And what we'll do now is we're going to jump into what's coming up with APhA. There's some breaking information, so I want to pass it over to Mitch first, and then we'll go to Elisa Bernstein. So thank you so much.
Okay, great job, Amina and Coleman. So one of the updates we wanted to give is to make folks aware of before the holidays, ACIP met. They talked about the new influenza updated guidance for the upcoming season. I wanted to make the audience aware of some of the tweaks to the language in terms of timing of influenza vaccination that was recommended by ACIP, still has to be affirmed by the Secretary and published in the MMWR. But in terms of non-pregnant adults, the recommendation is that during July and August, you should avoid vaccinating during those times unless there's concern that later vaccination might not be possible. So the language is similar to what's been in the past, a little more directed than it's been in the past, still leaves some flexibility for providers and interpretation. The leaning towards doing it later in the season, especially in the adults, is because concern with waning immunity. In terms of children, if a child still has to get 2 doses, is to give the first dose as soon as the vaccine becomes available, but get the 2 doses done ideally by the end of October. Remember, you do the first dose and then 4 weeks later, your second dose. And then children who only need 1 dose, again, vaccinate them by the end of October. Again, we're not really as concerned if you give it earlier, according to the CDC, that they're not worried about the waning immunity in children as they are in adults. And then on pregnant individuals, the recommendation still exists. You can vaccinate anytime during the pregnancy. They specifically put some language in the new updated recommendations related to 3rd trimester vaccination, again, trying to have the protection for the newborn in the first 2 months of life for them. So again, vaccinate pregnant individuals anytime during that pregnancy with some more specific attention to that 3rd trimester.
Great. Thank you, Mitch. I appreciate it. And that's going to be in the handout also, so you can reference post-webinar here. So we'll pass it on to you, Elisa, on some breaking news.
Great, thank you. So some breaking news came out this morning from FDA. As the last administration was very much in favor of using drug importation programs or policies as ways, that is importing drugs from foreign countries as a way to lower drug costs. The 2 of the programs and proposals that were announced one involved importing insulin from other countries into the United States, and the other involved a program for personal importation, so individuals importing drugs from other countries into the United States. And so there were requests for proposals out. What was announced this morning is that FDA did not receive any proposals. And because of that, they are stopping, halting any more, receiving any more proposals, and they've withdrawn the request for proposals. This is really good news for us. APhA welcomed this action because we have long opposed prescription drug importation schemes because of the patient safety issues as well as the vulnerability that it introduces into the drug supply chain. So great news there from FDA. Also, I wanted to give you an update on, if we can go to the next slide, please, Also, just recently, so as you all know, all the different states have put in place different emergency actions that provides pharmacists and other healthcare professionals flexibilities during the pandemic. A lot of these state flexibilities are expiring, and questions have arisen about whether, well, what about the federal PrEP Act authorities? How does that relate to the state ones that are expiring? So in response to these questions, HHS issued a clarification just last week, and they said that the federal authority for pharmacists and student pharmacists to order and administer COVID-19 vaccines, and for pharmacists, pharmacy interns, and pharmacy technicians to administer the recommended childhood vaccines, that is maintained irrespective of state laws or regulations. So throughout the pandemic, HHS has provided specific authorities such as these to ensure greater access to COVID-19 vaccines and testing, and that was through the PrEP Act. And if you've watched these webinars, I've talked about the PrEP Act many times. And what the PrEP Act, though, does is it has a preemptive effect, which means it supersedes state laws that are in conflict. And so this is good news, which means if your state authority or emergency action expires, you are still authorized to administer COVID vaccines and tests and childhood vaccines because of the PrEP Act. Now, what does this also mean is you should be working with your state associations in order to make the authorities during the pandemic permanent in your laws and regulations, because once the PrEP Act does expire, it will revert to what is allowed under your scope of practice in your state. So next slide. Once again, continue to push and offer that there are two really important laws and bills that are pending in the US Congress. One related to provider status and making pharmacists eligible providers under Medicare Part B, as well as a law that would reform the DIR fees. These are really important laws, and APhA has a way for you to write your legislator and your policymaker and to tell them that they should co-sponsor and support these bills. So if you go to the APhA Action Center, and the link is right there, you can get access to easily send with a push of a button letters to your specific legislators in your state. So if we can go to the next slide, please. This is also a reminder that APhA staff has been developing throughout the pandemic amazing resources for you, and we have a really nice database at our COVID-19 practice resource library. These resources are continuously being updated, and what you see here on the slide are 3 resources that were just recently updated as a result of ongoing news information that's coming out related to COVID-19 vaccination, as well as reimbursement for pharmacists. So a lot of this information that I told you about and more will be, if you are an APhA member, later today or early tomorrow, you'll be getting the regulatory and legislative update email that goes to all members that has more information of new what's coming out from the Hill and federal agencies. So thanks, back to you, Sandra.
Thank you so much, Elisa. That's a lot of information to cover there. The next slide, we're just going to remind everybody that in partnership with the CDC, we have a microsite with a lot of amazing resources for pharmacists to address things that we talked about today, vaccine confidence, the video that was showed as we started the webinar today. Please check out this website. It's incredible. Lots of wonderful resources that are being updated continuously. And we're going to talk about upcoming CP webinar. In June, we're going to have ACIP update. We're going to have APHA's liaison member to ACIP will present the latest information from the June 23rd, 24th ACIP immunization meeting. There are also previous webinars available for CPE. One is on motivational interviewing to address vaccine confidence, and the other one is a role of health equity in vaccine hesitancy. And please make sure to access those for continuing education. The next webinar we will have is on Thursday, July 22nd from 1 to 2 Eastern Time, and we will be addressing updates on vaccinations, new recommendations, deferred maintenance questions. As you saw today, Mitch shared some information, so we're just going to address the whole concept of vaccinations and give you all an update on what's going on. So make sure not to miss that. We will also have today's webinar recording available shortly. And this will be CE that you can assess. We're going to share the code with you. This is how to review and claim your credit. But this webinar will also be available as a home study to claim the CE later. So you're not going to just be, contained to this presentation. You will be able to claim the CE later. And if we can go to the next slide, please. This is the post follow-up question. So let's see what we learned. The first question again is, which of the following is not a common misconception and emerging drivers of mistrust in the COVID-19 vaccines? All right, and that is a correct answer. 94% of you, they are highly effective versus hospitalization from the Delta variant. That is the correct answer. Question number 2, which of the following is a solution for building trust with patients? All right, and B is the correct answer. Provide regular updates about what is known and be transparent about what is not known. And the last question for today is, if a patient has a history of myocarditis or pericarditis prior to COVID-19 vaccine, CDC currently recommends a patient do the following. Very good. Receive any FDA authorized COVID-19 vaccine after the episode has completely resolved. And that's the correct answer. And again, we have the handout for you to be able to take with you. Thank you again for joining us today. And thank you again, Amina and Coleman, for a wonderful presentation. And thanks to the CDC for helping to sponsor this.